Hello, everybody, and welcome. We'll get started here at the top of the hour. Okay, it is 12 o'clock Pacific Standard Time, so let's get started. Welcome, and thanks for joining us today. My name is Alan Barr here at COEH Northern California, and on behalf of the NIOSH-supported education and research centers throughout the country, we're pleased to present another installment of the 2020 ERC Ergonomics webinar series, offering free monthly webinars on various topics on human factors and ergonomics. This collaborative effort on behalf of each ERC's continuing education program aspires to provide access to current research supported through NIOSH ERC programs. Thank you again for joining us today. If you logged in today with your registration email, you'll receive a link to the recording and an evaluation form that'll qualify you for a certificate of completion worth 1 continuing education contact hour. A quick note that we do have another ERC webinar coming up on November 18th at noon Pacific time. And the title is Emerging Technologies, the Future of Ergonomics. This is in partnership with North Carolina OSHERC. For today's webinar, you will be muted during the presentation, but if you'd like to ask a question, and we certainly encourage you to do so, please enter it into the online Q&A box rather than the chat. It's a little easier for us to keep track of. And we'll save some time at the end of the presentation to address your questions. Today's webinar will be recorded and made available with past webinars on the COEH Northern California YouTube channel. Please take a moment to like and subscribe to our channel to help us continue to grow. Today's webinar is titled Minnesota's Safe Patient Handling Act, Policy, Practice, and Research, and it's presented by Breca, Tschida, and Christina Rosebush in partnership with Midwest Center for Occupational Health and Safety, ERC, as well as the Minnesota Department of Labor and Industry. Among other topics, this webinar will provide a history of the Minnesota Safe Patient Handling Act, a law designed to protect healthcare workers from injuries caused by lifting and transferring patients. And we're lucky enough to have 2 speakers today, Ms. Breca Tschida and Dr. Christina Rosebush. Breca is an ergonomist and industrial hygienist for Minnesota OSHA's consultative group, Workplace Safety Consultation. She's a certified professional ergonomist and has an MSPH in industrial hygiene. And prior to working for the Minnesota Department of Labor, she was a private consultant in industrial hygiene and ergonomics. Breca has also worked as a health compliance officer and senior member of the ergonomics team for OSHA compliance with the North Carolina Department of Labor. And also with us is Dr. Christina Rosebush. Dr. Rosebush is a recent graduate of the Occupational Health Services Research and Policy Program and a postdoctoral fellow at the University of Minnesota. And her research focuses on the health and safety of direct care workers in long-term care settings. Prior to coming to the University of Minnesota, Christina worked as an environmental epidemiologist at the Minnesota Department of Health and project manager for the Minneapolis VA Evidence Synthesis Program. With that, it is my pleasure to hand the mic over to Dr. Rosebush.
Thank you so much for the introduction, Alan, and thanks to everyone for joining us today. One moment, I'm having trouble forwarding my slides. There we go, just a little bit of a delay there. Breca and I are happy to be here to discuss Minnesota's safe patient handling work with all of you. Just to lay out a brief agenda, Breca will start by sharing the background of the law and talk about support that our state programs currently offer healthcare facilities as they develop and maintain their safe patient handling programs. Then I'll share the results of a policy evaluation that we conducted at the University of Minnesota and Department of Labor and Industry using workers' compensation data. This evaluation was focused on the effectiveness of the law in nursing homes specifically. We'll wrap up with our thoughts on where safe patient handling policy, practice, and research are headed, and then we'll open up the floor for discussion. This work was supported in part by a pilot project grant from our Midwest Center for Occupational Health and Safety, ERC. I wanted to share a quick story out of North Carolina to set the stage for our work today. This case is courtesy of the NPR feature Injured Nurses that came out several years ago and is really amazing if you have a chance to check it out in full. In 2008, Terry Cawthorn had been working at Mission Hospital as a nurse for 20 years and was considered one of their most reliable employees. She was injured on her 45th birthday while manually transferring a C-section patient from a gurney to a bed. And in her words, it instantaneously felt like hot tar was going down her spine. Terry reported that injury and returned to work. She was re-injured twice lifting patients the following week. The hospital argued that her back injury was caused at home lifting a dinner casserole out of the oven. They rejected her workers' compensation claim and terminated her position. Though Terry was eventually compensated in court, she can't return to nursing and has lost that part of her identity as a caregiver. Stories like these have inspired nurses' associations to call for laws to help prevent injuries caused by lifting, transferring, and repositioning patients. Minnesota is one of 12 states to have passed a safe patient handling law between 2005 and 2015. The American Nurses Association, which has a very large presence in hospitals, was responsible for much of the advocacy behind these laws, so hospitals were really the initial focus. The states in blue shown here require safe patient handling programs in hospitals. The states in orange require programs in hospitals, nursing homes, and some other healthcare settings. And Breca will share more details about Minnesota's law with you now.
Thank you. So there are two safe patient handling statutes in Minnesota. There is 182.6553 and 182.6554. For most of this talk, we're going to be talking about 182.6553. And it was really the first one enacted in Minnesota. It was enacted in 2007, and it covered licensed healthcare facilities. These were defined as hospital, outpatient surgical centers, and nursing homes. The statute was phased in over time, with sites required to have a written program, a safe patient handling committee, and a facility hazard assessment by July 1st of 2008. By January 1st of 2011, the sites were expected to have a full program in place, including equipment such that it minimized manual lifting. Next slide, please.
Sorry, Breca, I'm getting a delay here.
That's okay.
There we go.
Thank you. So you can see sites had time to phase in a safe patient handling program. They weren't expected to have all of their equipment in place until 2011. They had different dates for phasing in. In 2015, we did amend the statute such that the definitions of a healthcare facility were defined by NAICS code rather than by licensing. OSHA defines industry by NAICS codes rather than how they are licensed. And so we had trouble when we went into facilities trying to argue with them about how they were licensed versus how OSHA tends to define them. We also looked at adding assisted living facilities to the covered facilities. But because of the arrangement, the landlord-tenant agreement that was in place, and the type of relationship that presented, we couldn't add them as a covered facility. So we do know that there were risks associated with those types of facilities, but they weren't included under the statute. Next slide, please. There are many types of safe patient handling equipment that a site can use, anything including a non-powered sit-to-stand, a powered sit-to-stand, ceiling lifts, floor-based lifts, friction-reducing devices, and bathing systems are great for using to reduce patient handling issues. Next slide, please. So focusing on that particular statute for hospitals, nursing homes, and outpatient surgical centers, the statute required that each site have a written program, a safe patient handling committee, conduct periodic training, and have a written hazard assessment. And the written program had to contain specific elements. They had to have an assessment of the hazards at the site. They had to detail how they were going to be purchasing safe patient handling equipment. There had to be training on the equipment. There had to be information on what the site would do if there was a modification to the site or construction to the site, and it required a periodic evaluation as well. Next slide, please. Each site was required to have a safe patient handling committee. It could be an existing committee or it could be a newly formed committee. It has to be at least 50% non-managerial direct care staff. And if there was union representation, the workers on the committee would be selected by the union. The distribution of the members of the committee sometimes presents challenges for sites. They often try to use a safety committee to fulfill this committee requirement, but it usually fails to meet the committee makeup. So that's been a challenge for sites. Next slide, please. If anyone's familiar with how OSHA writes their standards, the word shall is pretty important. It basically means do everything as written, and you really don't have a lot of room to try to freelance on it. So the requirements of the Safe Patient Handling Committee were that they had to make recommendations on the training, on the use of the equipment. They had to do an annual evaluation of the safe patient handling program at the site and how the site was progressing towards goals established in the handling policy. They had to recommend procedures to make sure that remodeling of patient care areas accommodated safe patient handling equipment. And then they had to complete a hazard assessment that included how patient handling tasks were being conducted, types of nursing units, what the population was, the physical environment of where the care is being provided, were there problem and solution areas? Were there problems and solutions? What were the areas of highest risk for lifting injuries? And then recommend a mechanism to track and analyze those injury trends. Next slide, please. So I came on with workplace safety consultation in 2009. So the standard had already been enacted and was in the process of being pushed out to stakeholders. So I had the fortunate opportunity to travel the state of Minnesota in January to educate stakeholders about the statute, what it meant, what it was going to be requiring them to do. In Minnesota, there are 7 economic regions, so I got to travel to each one of those during that winter period. In addition to that, I've do basically on-site visits. I'm a field person, so I will go out and visit sites at their request. I do training sessions. We've developed alliances with various sites on safe patient handling and developing resources for that. I have 2 work groups that I basically facilitate maintaining the website. I also developed the sample programs for the requirements for the written programs. As you can imagine, people looked at it and did it many different ways. So having templates available was helpful. And then we planned 2 conferences, and I support Minnesota OSHA enforcement with their maintenance of the directive. Minnesota also has grants for safe patient handling equipment. We've done a research and statistics study. One of the work groups that I work with and have for about 11 years is the Facilitated Hospital Group. And it initially was a way for hospitals in Minnesota to connect and share ideas about safe patient handling. We've since expanded to an email group and extended the group to, I think, every hospital group in Minnesota. We hold quarterly meetings, both in person and virtually, to discuss challenging areas with safe patient handling. And I've worked with Christy on this project. So Christy, I'm going to turn it back over to you.
Perfect. Thank you so much, Breca. So getting back to the background of our research project, these are data from the Bureau of Labor Statistics Survey of Occupational Injuries and Illnesses. And this chart shows all recordable injuries and illnesses in US and Minnesota nursing homes and hospitals. It's notable that injury and illness rates are higher in nursing homes than hospitals, but declining over time in both settings. However, the rate in Minnesota nursing homes was still quite elevated in 2017 when we started this research. So that was really some of the inspiration behind this project. So why are injury rates elevated in nursing homes? Overall, patients are higher acuity or higher need, so patient handling happens more frequently. It's a challenging environment for lifting and transferring. Think of tight patient rooms and bathrooms, as well as daily schedules. Most patients must be transferred to a dining room within a short window of time 3 times a day, for example. Finally, direct care staff in nursing homes are mostly nursing assistants. These workers receive low compensation and few benefits and have high levels of responsibility at work and at home. They are disproportionately women, racial and ethnic minorities, and single mothers, and they are not empowered to participate in workplace safety culture on the job. CNAs have some of the highest musculoskeletal disorder rates of any occupation, as these data from the 2017 SOI show that their rate of MSD is up there with firefighters, EMTs, and bus and transit drivers. There's very limited literature evaluating safe patient handling laws, particularly peer-reviewed literature, and the focus is again on hospitals. In the 5 years a hospital-specific law was rolled out in Washington state, there was a larger decline in musculoskeletal injuries in hospitals compared to nursing homes, which were not subject to the law. On surveys, Washington healthcare workers reported improvements in knowledge of safe patient handling policies, equipment, and safe patient handling training relative to workers who were surveyed in Idaho, a state that did not have a law. In California, hospital workers, nurses specifically, reported similar improvements on a series of surveys. They reported that musculoskeletal symptoms declined over 4 years, but did not report changes in prevalence of work-related injury. Because these evaluations of state laws are so limited, we can look to the literature on voluntarily implemented safe patient handling programs for more guidance. As a whole, results are promising for nursing homes. Workers' compensation claims and costs have declined following implementation of safe patient handling programs. However, these studies are generally quite small and use pre-post designs without external comparators. So with that in mind, the goal of this evaluation was to look at trends in patient handling injuries in Minnesota nursing homes before and after the Minnesota Safe Patient Handling Act was enacted. First, by assessing changes in indemnity claim rates over time, hypothesizing that the claim rate would decline from pre-law to post-implementation, and then assessing whether changes in injury rates over time varied by facility level staffing characteristics, namely worker retention and staff hours per resident day. And we hypothesized that nursing homes with high staffing and high staff retention would experience greater reductions in their claims over time compared to other nursing homes. We compiled data from 3 sources. The first was the Brown Long-Term Care Focus Database. This is a national data set that includes mostly Medicare and Medicaid or CMS data. For many measures, it's more useful than CMS's Nursing Home Compare because it isn't limited to those CMS quality measures. And it's also publicly available, already cleaned, and standardized across states. So we pulled the majority of individual nursing home characteristics that you'll see in our model shortly from this data source. Next, we pulled data from our state nursing home report card. These data are designed to inform nursing home choice for Minnesota residents and their families. Data are from reports that Medicaid certified nursing homes submit annually to the state. In Minnesota, our Medicaid program is the Medical Assistance Program. We used estimates of worker retention, annual retention, and number of workers, which we used as our rate denominator for each facility from this source. And the report card is publicly available, but we put in a separate data request for more granular data. The nursing home report card is maintained by the Department of Human Services in Minnesota. Finally, our injury and illness data come from the state workers' compensation database, and these are the only data we use that are not publicly available by law. For each claim, we have injury source, nature, event, and body part injured. And each claim is pre-coded by Department of Labor and Industry staff using the occupational injury and illness classification system. So we relied on these 4 fields to determine musculoskeletal disorders and patient handling injuries. In Minnesota, only indemnity claims are captured in our workers' compensation database. So these lost time claims involve payments for wage loss or permanent disability. They also include settlements which stem from disagreements about the circumstances or severity of an injury, often between employee and employer. The database does not capture claims that only result in payments for medical treatment. And I should mention that depending on the year, this is between 70 and 80% of claims. So we're really only capturing the tip of the iceberg here. We've got between 20 and 30% of claims, and therefore they're the most severe claims reflecting the most severe injuries. So here are the data elements that went into our models. We were primarily interested in how time period, staff retention, and staff hours per resident day impacted injury claims. If you think back to the timeline slide that Breca shared, we looked at time period categorically to reflect the way that the law was rolled out. So we had a pre-law period, implementation, and 2 post-law periods. Conveniently, they were all 3-year periods. We included a variety of facility level covariates, mostly from that Brown long-term care focus data based on a directed acyclic graph. And we looked at several injury outcomes. We were most interested in comparing time trends in patient handling and non-patient handling injuries. And using those OICS codes that I mentioned, patient handling injuries were all injuries for which the injury source was patient, resident, or client, and non-patient handling injuries were everything else. So a pretty cut and dry definition. Touching just briefly on our methods, we first looked at trends in staffing and facility characteristics over time. And then we used negative binomial regression models to estimate unadjusted and adjusted indemnity claim rates by time period. Finally, we used interaction terms to see if the relationship between time and injury varied by levels of worker retention or staff hours per resident day. So this slide is a little busy, my apologies, but this is just our descriptive table. The highlighted variables show changes over time. So if you look at the slide moving left to right, we're moving from pre-law to the post-law period. And we see that facility level staff retention decreased, staff hours per resident day increased, and average resident acuity increased. The majority of nursing homes across time retained less than 75% of their workers each year. And that's actually better than estimates from studies of other regions. We know that nursing assistants in particular have incredibly high rates of turnover, often exceeding 100% per year. Here are time trends from our unadjusted models. We saw declines over time in total indemnity claims, and that was really driven by patient handling claims. Non-patient handling claims were steady over time. There was no statistically significant change. I should note that musculoskeletal disorders and patient handling injuries shown here are not mutually exclusive. So this is just showing that the grand majority of total MSDs were in fact patient handling injuries. Here's a look at our patient handling claims subcategories by time period. Because we used those OICS codes to define them, the broad category captures all injuries attributable to patient, resident, or client. If we look just at MSDs, we see a significant decline over time. The next most common category of these injuries was violence, and injuries attributable to resident violence did not change over time. The other category is unfortunately a little bit of a grab bag, so that significant difference by time period does not tell us much without diving more into the data. And here are the unadjusted results for non-patient handling claims over time. Slips, trips, and falls had a significant uptick in our 2008 to 2010 time period. And that other category also showed some significant movement. MSDs did not change over time for these non-patient handling injuries. Finally, when we looked at body part, the difference between patient handling and non-patient handling claims was most striking for back injuries. Across time, back injuries were 57% of the patient handling claims and only 26% of the non-patient handling claims. And you can see the clear difference in trend over time, excuse me. Here are the results from our adjusted models. The second column shows results for patient handling claims. The third column shows results for non-patient handling claims. Controlling for facility characteristics, patient handling claims were 25% lower in the second post-implementation period and 38% lower in the second post-implementation period compared to pre-law. We also saw a 20% decline in non-patient handling claims in the second post-implementation period only. Our interaction terms between time and our two staffing variables were not statistically significant, so those were dropped from final models so that we could interpret the main effects. However, we did see some interesting main effects with retention. Facilities with over 75% worker retention across time had a 17% lower patient handling injury rate compared to facilities with less than 65% annual retention. And that was not a pattern that we saw in non-patient handling injuries. Facilities in the Minneapolis-St. Paul Metro, hospital-affiliated facilities, and for-profits also had lower patient handling injury rates, and Metro and hospital-affiliated facilities had lower non-patient handling injury rates as well. So in summary, we saw greater declines in patient handling injuries compared to non-patient handling injuries in the years after the Minnesota Safe Patient Handling Act was passed. The association between the law and patient handling claims was not modified by staffing levels or staff retention, but facilities with certain characteristics had elevated claim rates overall. At the state level, mechanisms to support this law are already in place, and several of those were discussed by Breca. There's the grant program and the MinOSHA consultation program that she runs. And these programs can use these results to target groups of nursing homes with elevated claim rates to address patient handling injury disparities across our state. We also looked at individual facilities, and we found that 45% of them did not show a decline in injury rate over time. So we do have quite a bit of room to improve in Minnesota. So why do we think that some groups of nursing homes still have elevated patient handling injury rates? Worker safety is not always prioritized in nursing homes in light of many competing goals and requirements. There's a tension between safety and rehabilitation goals. Rehabilitation staff are working to maximize residents' functional independence, and an over-reliance on patient handling equipment is often perceived as a hindrance to that goal. Reinforcing that is the traditional CMS reimbursement model, which is based on resident function, progress, and outcomes. And then there are all of the state and federal quality regulations, which inform public-facing nursing home ratings. So those are really high priority. Addressing all of this while maintaining profitability or sustainability is no minor feat and is particularly challenging for nursing homes with limited resources. I also want to mention again the unique power dynamics in nursing homes. Patient care plans, which include equipment directives, when and how to use patient handling equipment, are maintained and updated by nurses and executed by CNAs. So there's this disconnect between the workers who know the residents' day-to-day function best and the workers who are maintaining the care plan. We co-developed fact sheets at the University and Department of Labor to disseminate our results to stakeholders. Our stakeholder groups include nursing home owners and managers, direct care workers, safety advocates, and local and state legislators. These will be distributed through the state's Safe Patient Handling website and directly through the mail. And hopefully someday in the future, we'll have some in-person presentations as well to share these with workers. With all of this in mind, what do we see happening with safe patient handling policy, practice, and research going forward? The bulk of state laws were passed before 2010, and federal proposals in 2013 and 2015 were not successful. If our strategy is to pursue new legislation, we need to shine a spotlight on ergonomics in the context of total worker health, making the connection with worker safety issues that are really holding the public's attention today, like personal protective equipment and staffing concerns. Alternatively, or in addition, we could put our energy into supporting healthcare facilities that already have programs. Several studies of nursing homes in states without laws have shown that most do already have a safe patient handling program in place voluntarily. So the question may be, how can we make sure that those existing programs are successful? Perhaps with more equipment grants and free trainings, by enhancing safe patient handling requirements and direct care worker curricula, or providing workers' compensation insurance incentives for facilities that demonstrate successful programs consistently. Finally, we should be comparing CMS requirements to safe patient handling goals to identify areas where safe patient handling is potentially being disincentivized. Regarding practice at the state level, we can build on efforts to identify best-in-class programs and share their strategies with other nursing homes. A great example of this from one of Breca's safe patient handling work groups is a nursing home that holds all of their committee meetings on the floor instead of in a conference room. So ergonomics issues are identified in real time and discussed as they occur. We can work to extend the reach of safe patient handling support beyond major metropolitan areas. In states like Minnesota, much of the support is offered to facilities via in-person trainings and meetings. This shift that we've had to virtual work environments and workflows opens up new opportunities to develop online trainings and support for more rural facilities. Better enforcement is needed. In Minnesota, only about 30 citations for unsafe patient handling have been issued under the law since 2007. We need to more clearly define manual handling and how to reduce it in our written standards so that nursing home staff and OSHA inspectors alike can easily identify it. And we should also disseminate methods for nursing home staff to easily estimate the amount of patient weight they are moving. Staff may self-regulate better if it's clear they are performing a manual handling task and moving a lot of weight. Finally, thinking about research, there are promising workers' compensation data sources at the state and national levels that may enable more comparison of patient handling injury trends. For example, the National Council on Compensation Insurance already collects claims data on MSDs, and we have a similar insurers association in Minnesota, as do many other states. These data could be leveraged to compare injury experiences in states with and without safe patient handling laws. There are, of course, limitations. The requirements of safe patient handling laws vary quite a bit state to state, as do workers' compensation systems and the work of our enforcement agencies. Nonetheless, this is one of the most standardized national data sources that we could use for a project. Locally, we could also think about leveraging OSHA injury and illness logs to track less severe injuries. As I mentioned, we know our work comp data is only capturing a sliver of the experienced injuries. The challenge with using OSHA logs is that employers are not required to submit their full logs to a government agency, so obtaining the logs requires quite a bit of coordination and cooperation from employers. The Department of Labor and Industry has done some small pilot studies collecting these data, and it was certainly a challenge. The response rate to the request was fairly low, and we would guess that more motivated facilities are submitting their logs, so they might not be an accurate representation of what's happening with injuries throughout the state. Finally, building on the findings from our evaluation, we should explore the association between worker retention and patient handling injuries more. Is retention impacting patient handling practice directly because more experienced workers are more familiar with safety policies and their residents? Or are retention and injury rate both a reflection of the work environment? That is, nursing homes with a healthy work environment both retain their workers and have effective safe patient handling programs. Here are some resources if you'd like to learn more about the work that we presented today. The MinOSHA Safe Patient Handling website includes the resources Breca discussed, including sample safe patient handling programs and materials from our state safe patient handling conference. And there are 2 publications related to the evaluation I presented today. The first discusses time trends in injuries, and the second focuses on differences in injury rates by occupational group. And finally, feel free to reach out directly if you'd like to talk more or are interested in collaborating on future research. Thank you so much for listening. I think we actually wrapped a little early, so we have several minutes for questions and discussion.
That's fantastic. Thank you so much, Christina, and thank you, Breca. That was an excellent presentation. Breca, I'll ask you to unmute your mic, and then we can take some questions here. And I do have a few for you. I'll start at the top. I'm going to read these verbatim. So I think Breca and Christina also have access to these. If you'd like to read it, you may. For states that do not specifically legislate type safe patient handling programs, does OSHA simply reference general duty clause and look to industry best practices as a means to encourage the development of SPH programs?
So I'll take that one, Christy. Yes, that is generally how it works. So if there are states that don't have specific legislation, the general duty statute does apply and would be used. And for a period of time, actually, Region 5 OSHA out of Wisconsin had a physical therapist that was doing compliance work, and I believe she actually had, over the course of the same time of our safe patient handling statute going into effect, I think she had 4 citations that were issued to nursing homes and other facilities for safe patient handling violations. So definitely the safe patient handling could be cited under the general duty if it wasn't a specifically covered item in that state.
Great. Does the Minnesota SPH legislation prescribe building construction requirements to support safe patient handling, or does it reference another standard or guideline?
It only requires that.
Basically,
oh, sorry, go ahead, Breca.
Yeah, go ahead.
It only requires
go ahead.
that construction must be considered. That safe patient handling must be considered for building construction. I don't believe that there are references to more specific guidance. Is that correct, Breca?
Yeah, and there is a guidance document out there for the design of healthcare facilities to basically accommodate safe patient handling. And a lot of the sites, and I'm drawing a blank on what that document is right at the time, and I can find it. But it was something that I would share with sites on how to develop how to work with their facilities to basically reduce things that would be problematic, such as the transition into the shower, or possibly transition from the room, or things like carpeting. And so I'm going to find that document on my hard drive, but it wasn't specifically detailed in the statute. It would be part of the hazard assessment. So if you were evaluating your facility and you realized that people were having trouble moving the lift around in the room, whether it was carpeted or there was some kind of transition in there, or there were cords, sometimes even just having 2 people in one room were problematic, or the residents, if there were clothes on the floor or things, those things would be identified as challenges to safe patient handling, and as part of the hazard assessment could be addressed that way.
Okay, I have a couple of questions that sort of combined here. Does the legislation differentiate between hands-on training versus theory-based training? And or for instance, would a demonstration for ceiling lift use qualify that a worker would be sufficiently competent for safe use? And a related question is, are there any findings on which training method is more effective? Hands-on versus learning modules, or frequency of training, etc.
So the statute does not specify the training method, so it is not specifically required to do hands-on training. But in my years of work with the hospitals here, I can tell you that they have gone to a lot of them, and a lot of also the nursing homes, when they do their initial training for staff, do hands-on, and then there is a lot of return on training for insurance of competencies, although that's not required in the statute. But we do know that that increases effectiveness of employee retention on the use of equipment, particularly in places where employees may not use the equipment on the day-to-day basis. In the nursing home, the use of equipment is pretty much almost hourly. I mean, they're using it so much. They're just moving, boom, 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 and using equipment. So they have a pretty good retention on what they're supposed to be doing. It just tends to be when someone's new and uncomfortable with a piece of equipment. So I think I covered all the items.
And I'm not aware of literature that directly compares more theory-based training to hands-on training, though participants certainly jump in if you are aware of it. What I've seen is generally pre-post studies of one specific training that is either theory-based or hands-on or a hybrid, rather than a direct comparison of the two modalities.
Okay. Were there any identified successful strategies to combat the high worker turnover outside of focusing retention and increasing training frequencies? For instance, the idea of peer coaches or training managers / supervisors.
It's not something that we looked at in this study, though we're certainly interested in it for future research. It would need more of a mixed methods approach. Though anecdotally, Breca, do you have anything to share on those strategies?
Yeah, I was just thinking that I don't see peer coaches as often in the skilled care environment as I do in the hospital environment. And maybe that is just how they systematically set it up. Pretty much in the skilled care, I'm seeing teams of 2 individuals that work together to manage a certain number of residents, and I don't see any peer coaching happening unless it's like an initial training or something like that. But I see the peer coaching far more in the hospital environment than I do in the nursing home.
Okay, great. Thank you. How could the standard be improved in your estimation?
Oh, there's lots of ways.
Is there a number one? Is there a top item?
Well, it really kind of really focuses on a written program and on training, and that you have to have a committee, but it never really comes right out and demands that you reduce manual lifting, other than you evaluate your program and look at it. So it does have that as part of a topic, but it's really some of the language in it. It was written not by people that typically write legislation or write statutes. So, enforcing it as an OSHA person, and it's written by someone who's outside, the language is a little bit different. And we like to be OSHA language is very, thou shalt do this, thou shalt do that. So there's a lot of language in there that is a little bit different than an OSHA person likes to see.
And some of the elements like developing a mechanism to track the program over time and ensuring the program is effective just don't have the language to be something that could be checked by an inspector. Let me know if I'm wrong, Breca, but I don't think that tracking mechanism of injuries is something that's actually checked.
Well, and it's something that I figured out, but and I do the training for the new compliance officers, but it's, it's a method of like, okay, now you need to evaluate your injuries at your site and you need to use your OSHA record keeping, but it's not something that they're necessarily familiar with in a way that somebody who does safety and health at a manufacturing site might be accustomed to doing. In a healthcare facility, they're not looking at incident rates in this quite the same way in comparison to like evaluating a program. So it's just a little bit of a shift on mindset on that. So there is a way to evaluate it, but it is not obvious immediately.
Okay, thank you. Are you planning on writing up your work for publication?
We have 2 publications on the work that I presented today. And we also did a small study using workers' compensation data from a single insurer that compared nursing homes, hospitals, and other healthcare settings. So there is probably a 3rd publication pending based on that work. But for the state study that we presented today, the 2 publications on that final slide are the ones.
Great. Can you briefly discuss barriers to broader adoption?
Broader adoption outside of Minnesota or broader
Absolutely.
adoption to?
Absolutely, on
Yeah.
a federal level. Mhm.
Okay. Well, different states have different things they focus on and different levels. Like Minnesota's a state plan state. We're one of 26. So we have to be at least as effective as federal OSHA does, but we can also enact our own statutes, standards, and rules. And so that helps to be able to do those kinds of things. If it's a federally run state, if it's covered by federal OSHA and does not have a state plan, they're going to have to have a federal standard for it. So those are some of the limitations. That depends on the political climate in the state. If there's a lot of enactment of standards, there's some states that have. We saw that there were 12 states that have safe patient handling statutes and rules at the state level. So you can see that they are states that are pretty aggressive in terms of enacting standards for safety and health, more so than other states.
Sure. Okay, excellent. Let's move on. Question, would you wager a guess at the mechanisms by which the legislation may be reducing patient handling injuries? Is it equipment purchases, equipment usage, changing procedures, all of the above?
Oh, wow. Okay.
That's a great question. I would say equipment purchases is probably a large piece of it, especially for some of these smaller facilities that may have had really limited equipment or been relying on things like gate belts and slip sheets before the monetary support was available from the state. What do you think, Breca?
Yeah, I think it's just me going around and talking to people. No, I'm just kidding. There's I talk people into things, right? No, I think having the equipment and understanding that they can use that grant to purchase equipment. There have been a lot of safe patient handling equipment that's been purchased through that grant, and lots of things from ceiling tracks and ceiling lifts and bathing systems, a lot of stuff, and also then experimenting with the equipment and going, oh wait, this does something, we can use this.
And that actually makes me think the previous question that someone asked about what could be improved in the language of the statute. I think the statute says that each facility must have adequate equipment, and being more prescriptive as to what adequate means, how much equipment per head in each type of facility, I think would be a helpful addition to the law. Sorry to backtrack there.
Yeah, and some of that wasn't really, some of that information wasn't, it was pretty early on when that was being developed as to how many, based on what type of, tasks you're doing. So yeah, definitely having a good distribution and understanding what that looks like in terms of equipment.
Some of these excellent questions have come from Canada, a Canadian hospital ergonomist, and
Oh, nice.
And that person would just like you to know that this was particularly enlightening to hear specific legislation to support SPH, and that you're trailblazers, and thanking you for your valuable efforts. So I thought that was noteworthy. Just a
Oh, thanks for
comment in the
sharing.
chat.
Well, thank you. That's very, very kind.
I'm glad you finished early so that we could have time for this discussion, because this is a very interesting component. Here's another one for you. Other than the composition of the SPH committee itself, is there anything else that is looked at during inspections to determine if the committees are functioning as they were intended to?
Yeah, so like I said, I'm a field person, so I go out and do the inspections, and I do the majority of the safe patient handling ones. So I will look at the makeup of the committee. I will look at the activities that the committee has been conducting. I'll look at their hazard assessment. I will also talk with them. I'll basically take their OSHA 300 logs and break down all the injuries based on whether it is safe patient handling related or possibly interaction with residents. So I will show them where their numbers break down. And then we basically see where they're trending over a 3-year period based on those logs, whether they are staying the same or whether their incident whether their rate is going up, whether they are functioning healthfully. And then I'll talk to the members of the committee and I'll talk to employees. I actually developed a whole document for this because sites were having so much difficulty with their committees because of the turnover. Every time a new person came in, it was like they were reinventing the committee. So I worked with one of my work groups on safe patient handling to develop a calendar of activities. It's more fun than just your regular calendar. It's a safe patient handling committee calendar. And it had 3 years of activities that you could, you all got that, 3 years of activities that you could use for your committee so that if there was a turnover when someone left, you wouldn't lose all of your progress as a site. And so it would have fun things like analyze where your trends are and look at your numbers for the year, and then also go look at your equipment to inspect it. A lot of times sites really struggle with this because they really don't have time for so much committee activity. So we really have to think about how to have that committee functioning where they're not just sitting in a room and it's a large committee. It tends to have to be a smaller, streamlined, very active committee who is going out into the staff, the workers, and asking them and inquiring about how safe patient handling is going and what barriers there are and can they get equipment and what's happening. So we really have to think differently about how that committee functions. And that's something that I talk with sites about too. And I do train the compliance staff, the new compliance staff, to look at this. And then I also help with compliance staff who are evaluating it as well. So it's a learning curve for everybody to try to work with the statute, and we get better at it the longer we have it because we understand how to use it better.
That's great. Here's a related sort of follow-up to that. Do you have any suggestions or recommendations on improving cooperation between safety committees and safe patient handling committees?
So that's an interesting question. Oftentimes, what I find works is that the Safe Patient Handling Committee is a subset or a subgroup of the Safety Committee, and that they are bringing back information to that Safety Committee. Since the Safety Committee tends to be a larger committee and they tend to have sort of traditional meetings. So if you have interested parties, and really at a facility, it just takes one very interested person to basically get a couple other people interested. And to get that information and start collecting it and then share it with the safety committee to look at ways of improving it, but not necessarily operating in the same way as the safety committee does.
Okay, great. I think I have one more question for you, and that's, do you think that gaining access to 100% of claims data versus the current 30% of claims data would be a game changer, or does the 30% that you've currently evaluated really reflect all the meaningful trends and is compelling enough without that other 70-odd%?
I would say it's compelling enough to make me want to dig into the rest of the data. One concern that we have is, are we not making progress in preventing injuries altogether? Instead, are they getting less severe? So is the equipment helping, but are we still having employees injured while lifting and transferring patients, but just via a different mechanism? So we think of like those sit to stand lifts involve a lot more shoulder action from workers as they're helping push patients up. So I do think it would be a game changer to compare trends in these more severe lost time injuries to less severe medical only injuries, and then comparing both of those to the SOI data.
Excellent. And how do you go about getting your hands on that?
In Minnesota, we have to work with individual insurance companies. And so it's not representative of the whole state. It's just kind of a snapshot of the enrollees with that company, but it does give us access when we form partnerships with them to the full spectrum of work comp data. I believe in other states, the state systems do include all claims. So it would be interesting for those states to take a look at the more severe versus the less severe injuries.
Well, that's great. I think, one more just popped up. Would you be kind enough to put up the last slide with the resources briefly?
Sure.
Thank you. And we'll leave that slide up for now, and I'll have some closing remarks here quickly. You may learn more and register for our upcoming webinars at coeh.berkeley.edu. And you can also subscribe to our YouTube channel, where you can find recordings of previous webinars and other events. And as a reminder, if you logged in today with your registration email, you'll receive a link to the evaluation form that will qualify you for a certificate of completion worth 1 continuing education hour. And when I end the webinar, it will hang up on everybody. So I'd just like to take a moment to say thank you very much to our presenters. Wonderful job and very enlightening, as was mentioned before. And I'll allow the presenters to say goodbye as well. Thank you for joining us.
Yes, thank you so much. We really appreciate your time today and hope to hear from some of you in the future.
Definitely. Thank you so much.
Okay, good job, everybody. See you next time. Bye-bye.
Bye.